are very important people here today. They are the authorities worldwide known. Dr. Mona Bhatia, Chief of MRI and Imaging Center in Escort, Fortis Hospital in Delhi. And I have with me Dr. Bera, who is the Chief of Imaging in the Fortis Hospital, Gurgaon. Imaging is a very important modality. We know it in our heart. If there is no imaging, we cannot know anything and we will be totally blind in our understanding, in our management skills for any patient anywhere in the world. Imaging has really evolved over the last few years, and there are so much of advances that unbelievable. I am basically an echo man. It's also an imaging. So I do a real-time imaging by echo, but number of times I have to take the help of CT scan and MRI as a multi-modality approach so that I can give a better outcome or better results. So we have with us Dr. Mona Bhatia, a very pleasant lady. Let me see what she has to speak. Mona, we are welcome on this platform. And I really wanted to ask you, what do you think is the role of cardiac MRI in the years to come? Because do you feel, is there a competition between the MRI authorities and the echo authorities, or it's a complementary? And I'd like you to narrate some situations where echo could not pick up, but MRI did. Mona.
So echo definitely remains the cornerstone for imaging, because there is no way that we can do as many MRIs as we can do echoes. If you talk about a stadium full of people, then the total number of echoes that can be done is maybe about 200 times in the same time as we would do MRIs in a single day. So there is no question that MRI can never replace echo because of the facility being available on the bedside, being very fast, rapid, cheap, and available 24/7 in most institutions. When you talk about cardiac MRI, it's definitely got a very limited availability. It has a limited number of institutions that are doing it, and also the number of staffing that is required is different. The kind of clinical acumen required is different. So it's not something that can replace echo at any given point even today. As far as cardiac MR is concerned, the big advantage that cardiac MR today has is that it can assess the myocardium, something that echo could never do and no other modality could do to the same level of spatial resolution that we have with MRI. So MRI can actually assess and characterize your myocardium, which is where it is really important, particularly in a country like ours where we have tuberculosis, we have infections, we have myocarditis, we have little children who are less than 1 month old, have an upper respiratory tract infection, come with a heart that is dilated, working at 10% its value, and then in these situations we really need to look at the myocardium. If we can check for myocarditis and give them the immunoglobulins before we can even get the blood tests and have it approved on that, then it really makes sense, because we've saved that child and that saved that child's heart from any consequential damage. This is where we really think it makes a tremendous difference in the evaluation of myocarditis. There's lots of dilated cardiomyopathies that have always been there in our country, who in the past have been idiopathic. They've never known what was the cause. Now we know the infection, we know it's tuberculosis, we know we can treat it, we know we can improve it, we know that the patient will not have sudden cardiac death. So all that can now be evaluated and averted. So that's where we really need to look at it. There's a lot of cardiologists who come and say, I can handle the coronary artery disease, I can handle the ischemia. What I can't handle is my patient dying because of sudden cardiac death. Can I prognosticate that patient? Can I know which patient will have it? And that's where I think it makes a tremendous difference. If we can prognosticate the patients who have a chance of sudden cardiac death, what we need to do to prevent it. So that's where it's important.
So I think Mona has given a very important insight that MRI has a huge potential in identifying the myocardial disease, whether it's an inflammatory disorder or a degenerative or a ischemic disorder. And the Mona was very emphatic on it, that it is not only a diagnostic modality but also a prognostic modality and help us in the appropriate therapeutic intervention. Mona, I have one more question to you. I think we see these days a lot of CT NGOs, and we know there are a lot of radiations given by the CT NGO. And when I say a lot of radiation, means some people are more sensitive even to a small dose, and most of our population is CKD. They have underlying diabetes or hypertension, and they are highly vulnerable to have a contrast nephropathy even with a small dose. So dose is not a criteria. It is a sensitivity of an individual which is the criteria for creating more nephropathies. I would like to ask you, is there MR angio in pipeline for coronaries, or it's not feasible and it's not practical in the years to come? What are your viewpoints on this?
It's definitely in the pipeline. We have it in the future for sure. At present, what we can assess is the proximal segments of most of these arteries. So proximal coronaries can be evaluated, their origins. That part we can evaluate even today fairly well. But we still haven't reached the level of sensitivity and the spatial and temporal resolution that CT angiography as a non-invasive modality has reached in the evaluation of coronary stenosis. But for sure, MR will definitely pave the way forward for this if you're talking about no radiation.
We see a lot of renal artery stenosis in elderly patients, especially those who are diabetics. They have angiopathies, they have a microangiopathy or middle vessel involvement or a large vessel involvement, and they are already in CKD. So, as a clinician, I feel MR angio of the renal vessels should be superior as compared to CT angio for the renal vessels. What's your opinion on this?
For sure.
Setting of a CKD.
For sure. The renal vessels can be very well assessed without any contrast on MR. So MR has the capability to evaluate vasculature without any contrast. So that way, as far as all vessels other than the coronaries are concerned, MR can evaluate most vessels without any contrast. And in the event of a CKD or in patients who have even disturbed renal functions even mildly, we definitely prefer the MR angiography to the CT.
I think it's very important the message given by Mona Bhatia that MR angio is going to be the future, though it is very well validated, of angios in the coronary, angios in the renal vessels or aorta, or angio of the carotid or peripheral vessels. But so far as the coronary is concerned, it is only confined to the proximal part of the coronary vessels. But in the years to come, as the technology evolve, maybe CT angio may be replaced by MR angio. That will be a revolution. Thank you, Mona, for your nice comments.
Pleasure being
We have with us Dr. M.L. Bera. I know him for the last many years, and he is a very good academician and a authority par excellence in the imaging. Dr. Bera, you are doing a lot of angios, CT angios, and advances in CT. Does it really help in the last 3 years? Is there any change in doing the CT technology, especially assessing the coronary arteries or other vessels which are leading from the heart to the brain?
Yeah, there is a lot of changes taken place. So far the equipment is concerned. Now we have got multi-detector scanners above 250 slice and 320 slice, where in single acquisition can take the imaging. So in this case we have reduced our radiation dose tremendously, almost 80% reduction in radiation dose. Now dual energy CT scanners can do coronary angiogram even less than 1 millisieverts. My machine, I have got 256 slice from Philips. Invariably I am doing at less than 2 millisieverts, which is tremendous achievement. If I'll go back 5 years back to the 64 slice when I started at Apollo, almost 8 to 12 millisieverts was the radiation dose. So almost 80% radiation dose we have reduced. This is the one technological breakthrough I can say in reducing the radiation dose. So far image quality is there. Certainly we have improved a lot. Not only the basic morphological imaging, we have also advanced in various functional as well as etopathological factors to reduce, to determine, like normal calcium score, your normal anomalous origin course as well as plaque characterization. This is a common imaging protocols now with CT angio. Now beyond that, what? Now we are going about the acute chest pain in emergency department. This is a great breakthrough I can tell you, where by doing a simple coronary angiogram in a non-ST patients, we are able to achieve 58% reduction in hospitalization period, almost 35% reduction in the cost. These are the various advancements taken place because it has got a very high negative predictive value, almost 99 to 100%. So we are taking advantage of this aspect. Once we say there is no coronary disease, these patients can be diagnosed much earlier from the hospital with less cost to the patient. Similarly, functional studies, yes, there's a lot of development taken place in myocardial perfusion studies and CT-FFR, which are the major breakthrough in decision making, whether stenotic vessels need intervention or not. That FFR will give. Otherwise, earlier what we used to do, catheter angio plus IVAS, two factors are both are invasive and both are considered for vascular mapping and thereafter decision making. Now non-invasively we can do, which is a great breakthrough. I don't need any extra imaging, simple same acquisition for the morphological imaging, I can go for the CT-FFR. Now another etiopathogenesis like epicardial fat assessment, endothelial sharing states, these are the now latest in offing, and lot of software has been developed, but commercially nothing is available to assess these etiopathogenic factors which are responsible for atherogenesis and their progression.
Dr. Bera, I think you made a very important point. The CT angio has got a huge role, and even the dose requirement is reduced, and people are getting a lot of information. I just want to ask you, if a patient got a significant TVD and he's got a patient of CKD, what will be your recommendation? How many CT angios he can undergo in a year? 2 or 3 or 4 if required? Because there are people who are diabetic severely and the atherosclerosis progression is very, very fast. Even if they have angioplasty, the restenosis rate is very high. So we need to have a re-evaluation. So what is the frequency of re-evaluation possible? What are your recommendations?
That's absolutely based on your clinical assessment. If patient has developed restenosis clinical sign, then it has to be done. And in that case, CT is the possibly non-invasive modality. So far, diabetes mellitus CKD is concerned, these are the major constant for CT because you have to give ionic contrast, non-ionic contrast, which has got nephrotoxicity. But with the, if it is a borderline, then we can do with the isosmolar contrast.
Only one question more, Dr. Bera. I think recently it has been seen that a lot of patients of pulmonary embolism are being diagnosed. One of my own colleagues just recently before coming here had a pulmonary embolism, and he underwent an echo test. There was no evidence of pulmonary embolism by echo. We found his immediate trivial TR, the RA and the RB were absolutely normal, pulmonary artery pressure was absolutely normal, and there was no evidence of thrombus anywhere. But as he went for CT, he wanted to know whether it's a coronary event, and while doing a CT, they caught it. That is a filling defect in the RPA and LPA. Do you find the pulmonary embolism is the disease which can be diagnosed very meticulously and in a more effective manner as compared to echo? So far as the RPA, LPA or MPA is concerned, and even the peripheral vessel of the pulmonary artery, you can delineate better.
Yeah, CT is excellent modality so far P is concerned. In fact, while I was working at Apollo, I had given a thesis work to my DNB students, D-dimer versus CT angio. So we found lot of patients where D-dimer are negative, still we could get the pulmonary in chest pain. And even also with the present CT scanners, even tertiary vessels, smaller embolism we can detect.
The second question I really want to ask that this patient who is one of our doctors who had a pulmonary embolism in the RPA and LPA, and we put this patient on heparin. He was in All India Institute of Medical Sciences, and after giving heparin, there was a little debate. We had to reassess whether there is a dissolution of the thrombus or not. We did an echo and we found echo was almost normal. There was nothing much in the echo to say. But the debate was, should he go for CT angio or should he go for ventilation perfusion scan? And ultimately the patient decided himself. He's a doctor, he's a cardiologist. He said, no, I'll prefer to go for ventilation perfusion scan. And when the ventilation perfusion scan was done in the nuclear center, it was absolutely clear. So he presumed that there is no need for going for a CT because he was scared of the radiation. What's your view on this?
No, now you see, with the modern dual energy CT scanner, we can do ventricular perfusion studies as well as CT angio simultaneously with the iodine value whatever is there. But regression of the thrombus, it is even as partial recanalization, say 70%, still thrombus is there outside, perfusion will be normal.
No,
how to know what is the resolution of the thrombus?
My question is, a number of times we have to decide how long to give anticoagulants, because in this particular patient he has some surgical intervention for varicose veins and sclerotherapy. So this was the likely source. He had no primary cause, and there was no secondary cause here except what I'm mentioning to you is the sclerosing of the varicose veins. So even if you find there is a thrombus, a residual thrombus, will it make a difference so far as the therapeutic intervention is concerned, or we take it for granted that any such patient whose ventilation perfusion scan is normal, we give for 6-month anticoagulants and there is no need of CT angio?
That is a normal protocol. Once D-dimer should be there. Once a thrombus is there, once we assess them fast, there is there. Now it will go for chronicity. If it is not resolved, it will calcify, it will make a partial luminal obliterations, that will go for chronic stage. So then there will be, in late stage, they may develop chronic pulmonary thromboembolic hypertension. These are various aspects.
What is the protocol? Should we or should we not subject this patient for CT angio?
No, that is on the clinical assessment, absolutely.
Protocol. What is the protocol? The reason is, as I mentioned to you, echo is clear, patient is asymptomatic now. When he came to the hospital, on the slightest exertion while he's speaking, he used to have
No, truly speaking, on these regards, I haven't got any protocol. Neither I have, the best of my knowledge, might be there, but I don't know. I'm
so
confessing.
It's very, very important. I think Dr. M.L. Bera has mentioned very clearly, the CT angio has got a huge scope. We should not be worried. We can use the contrast, which is a very, very specific and will not produce an addition of an insult to the compromised kidney state. We can use the contrast in a small dose. It will not deteriorate the renal functions. And he also mentions very clearly that CT angio has a huge role, on the contrary, a role better than the echo for detection of thrombus burden, especially in the right pulmonary artery or left pulmonary artery or even the peripheral vessel of the pulmonary artery. And he says, though there is no appropriate protocol, but these patients can be followed meticulously, maybe after 3 months or 6 months, to see how much is the residual clot. I am really thankful to both Dr. Mona Bhatia and Dr. M.L. Bera for giving a very, very important information on the imaging technology in the years to come. Thank you, Dr. Bera.
Thank you.